Welcome to In the Interim. Today's edition is with Dr. Hanna Phan. In the Interim is a program that we've put together. I'm your host, Bruce Mueller. I'm the Interim Dean of the College of Pharmacy at the University of Michigan. And the purpose of In the Interim is to put together a forum where our students can network with alumni and leaders in the profession of pharmacy, and also some of our faculty. And it just so turns out that today's guest, Hanna Phan, is actually all three of those things. She graduated from the College of Pharmacy in 2003. For some reason, she went to a school down south that cannot be named in Columbus, Ohio, where she did a postdoctoral fellowship in pediatric pharmacotherapy. And after that, she went to Arizona. And she's developed her entire research career and practice career down in Arizona. We're going to talk a little bit about that today. And just recently returned home. She's our newest faculty member. I'd like to welcome Hanna Phan to our program today. Hi, Hanna.
Hi, how are you?
We're doing great. And I'll tell you what, we start every one of these episodes with a description of you look like you're just sitting in this wonderful place right now based on your background.
Right?
Where are you?
Yes, this is actually a picture that I took in the Arb a few years ago when I came back for a visit. So it's one of my happy places to be in Ann Arbor. So I get to go there more often now that I live here.
That's right. You work right nearby in Mott. I don't think anybody knows. In fact, it wasn't even in our show notes, but you do photography for fun.
Yes, I do. I did one wedding, and I will only do one wedding and I'm done.
Why is that?
It's true when they say about bridezillas when it comes to photographers, and so I prefer not to do weddings. And I prefer doing landscape photography, but I've done like pediatric, like kids photography for friends' kids and things like that. So yeah.
So anybody who's looking for a side gig, here it is. Or if anybody needs some photography done, as long as you're not bridezilla, Dr. Phan would love to talk with you. Well, you've developed a career that's really unique, and I don't know that anyone else has done what you've done, is to find this niche of really important area of pharmacotherapy, and that is working with people who have cystic fibrosis. And we don't talk a lot about cystic fibrosis really in our curriculum, and we've got a bunch of students on now. So why don't you give us the thumbnail, because not everybody's had anything about cystic fibrosis yet in their clinical rotations or even in therapeutics.
Wow, okay. We might have to change that in the curriculum.
There you go. I knew that was coming.
So cystic fibrosis is a multi-organ system disease. A lot of people affiliate it with pulmonary, but it has lots to do with infectious disease, GI, as well as even behavioral health to some degree. And I work with the CF team to help manage all the medications they're on. On average, my patients are on at least a handful of medications, if not more. The more advanced the disease they have, they anywhere range up to like 10 to 15 medications. And we probably are up there in terms of disease state with the most expensive medications. With the most recent addition, Trikafta, which is Lexicaftor, Tezacaftor, Ivacaftor, which is a mouthful.
How expensive is expensive?
About $300,000 a year for life.
That all. Wow. All right. So back in the 1930s when I went to school, this was a pediatric disease. It's not necessarily that anymore.
It is not. So prior to coming back to Michigan, I practiced adult and pediatric CF, as well as pediatric pulmonary in general. And my oldest patient was 77.
Oh my gosh.
So I did dabble in geriatrics a little bit.
Right. I mean, but because the pharmacotherapy's gotten so good that people are just living longer.
Yes. The pharmacotherapy, the airway clearance technology with the vest and everything has gotten much better. I still remember learning about inhaled tobramycin in my pediatric elective when I was here. And since then, so many medications have come out since then for patients, which is great, which advances their expected life expectancy, but it also creates polypharmacy, and that's where pharmacy comes in. Not every CF center in the country has pharmacy services as far as having a clinical pharmacist as part of the team, but it's a growing thing. When I went to Arizona, there was no service, and so I got to build services there, including a model with a technician. So I also had a technician that helped with medication access, prior authorizations, and connecting patients to patient assistance programs so that I could focus on the clinical aspects of the practice, medication management, collaborative practice agreement, and managing exacerbations with antibiotics.
Outstanding. So I want to just remind us ourselves that this is an audience participation kind of program. If people want to raise their hands and ask a question, or if they want to just chat them to me, we'll monitor the chat and put forth any questions that you have at any time that you're interested in doing that. Now, cystic fibrosis always would come up as the exception when we would have our pharmacokinetics class.
Yes.
And it really, underscored the need of why you had a pharmacist. What are these pharmacokinetic exceptions that we used to hear about, or maybe we still hear about, that really require a pharmacist to be there because textbook solutions don't work?
Right. So, for example, patients with CF often have a large volume of distribution for hydrophilic medications. So that includes your aminoglycosides, your beta-lactams. And so the dosing tends to be a little more aggressive, milligram per kilogram, and they get frequent courses of antibiotics over time. And so we have to balance being effective while also avoiding toxicity. And so this is the population you're probably going to see the most aminoglycoside kinetics done, if you're going to see it all in rotation or in practice.
And drug resistance, I suppose,
Yes.
is a problem as well.
Yeah. One of my pulmonologists used to call, when we got cultures back, he would say, oh, they have a pirate strain of a bacteria of Pseudomonas. And one of my trainees was like, what do you mean by pirate? R, like.
Everything is R.
Yeah.
Oh, that's bad. That's
that was a dad joke from him.
I know. Thanks for the dad joke. Usually that's my job, so that's great. Well, so you developed a practice again that I said is unique. How many Hanna Phans are there in the world who actually work in cystic fibrosis pharmacotherapy that are pharmacists? I mean, there's not many of you.
I mean, that's a growing trend. I would say that those that are dedicated to CF, we're growing about 50 plus in the country, if not more. Some people double dip where they're inpatient general peds, but they spend a little time in the clinic. And we're finding that although that model is helpful, it's not optimal to follow patients chronically and to really manage the medications longitudinally. Because I know that, general pediatric inpatient pharmacists are super busy as well. They have to manage so many patients and so many specialties on the floor. In order to pull away from clinic, it's hard. So having dedicated pharmacy services for that is really important.
Well, with all the students that are in the audience here, what's the job picture look like to somebody who wants to specialize in pediatrics as a clinical pharmacist?
So you'll need to complete a course for PharmD and then a PGY1 residency. It could be a mixed adult peds PGY1, and then you can matriculate onto a PGY2 in pediatrics and subspecialize from there. Some people have asked me, can I be a ped specialist after a PGY1? I would say that in some cases, yes, but in most cases, no these days. The job market is becoming where the more training that you can have or specialization that you can have and things like that, the better off you'll be as a candidate. And so if you wanted to be in a particular niche of pediatrics, it's advised to do a PGY2.
What made you think about pediatrics? I mean, we had to get you got your PharmD here, you treated adults and kids. What's from your perspective, the biggest differences between treating adults and treating kids?
For me, I'm a kid at heart, so it was pretty easy for me. But I really was fascinated with the difference and variability in drug dosing and drug selection in this population. It wasn't a cookie cutter solution. Not to say that even adults are cookie cutter, but it's even more diverse in pediatrics. You have neonates in the NICU whose metabolism and drug renal clearance are very different than what you would see from a 6-year-old from a 16-year-old.
And neonates are big bags of water anyway, and so they've got really wacky pharmacokinetics. Yeah, it's true. It just changes with time over kids. And the other thing, I guess that changes over time over the lifespan. The other thing that I've noticed with the pediatric practitioners that I've worked with are that there's a lot of art that uses science, but there haven't been double-blind placebo-controlled trials and all this kind of thing, and so you actually end up having to do some things with a lot of creativity, it seems like.
Yeah, we have to kind of go with our gut sometimes and get a little creative in terms of how we approach drug selection and dosing safely, of course. But if you are a guideline stickler kind of person,
go to cardiology.
That's
cardiology, right there. You're a guideline person. Yeah, all right. Well, what was it maybe as an undergrad or a P1 that made you think about peds, or did you not know that at that time? Well, look at so many students here who are just starting out and they're trying to figure this out.
Right. I'm probably the odd duck that didn't change my mind over the years. I volunteered at a children's hospital in high school, and then when I came to University of Michigan for undergrad, I volunteered at the children's hospital here, and then also helped with pediatric research as an undergrad. And then I met Varsha Mehta, Dr. Mehta, who's at Michigan, and when I got into pharmacy school, and she kind of reinforced that encouragement into pediatric pharmacy, and I never stopped from there. So I never really had a second guess of pediatrics in my career, but I think I'm probably the odd duck in that, because I know a lot of folks kind of switch between things even through school and residency. So that's totally normal. I'm the weird one.
Well, it's true. I mean, some students go on every, like me, when I was in school, I loved every rotation. And then I found a couple of rotations I hated. In fact, it's great to find out what things you hate, because it actually does narrow the field quite a bit. And so I'm trying to think, you've got a really narrow field, cystic fibrosis. How did you choose that?
So, I mean, way back when I was a student, I did my Gen Peds rotation with Dr. Johnson, and worked with Dr. Streetman at the time, and got to be exposed to a few CF patients while on the Gen Peds rotation. Really enjoyed that. And then when I came back and worked at Mott and helped fill in for things like kinetics and things like that occasionally, got to run into that same patient population. It still kind of piqued my interest continually. And then when I went to fellowship, I was faced with trying to figure out what I wanted to do as a faculty member from a practice standpoint. And I really enjoyed infectious disease. I really enjoyed chronic disease management and ambulatory care for kids. I had an asthma clinic as part of my practice as a fellow. And so when I went to Arizona, I discovered that they didn't have anybody in pediatric pulmonary medicine. And so I asked if it was okay for me to develop my practice and research program in pulmonary medicine there, and specifically in peds, and maybe adults if they really needed me for the CF part. And so that kind of stemmed from there, and it kind of mixed all of my interests all together.
It does. You've got a lot of things. There's like ID. There's all kinds of stuff in cystic fibrosis. So if somebody in our audience wants to get more involved in the cystic fibrosis sort of practice, or or just dip their toe in their water, because it's kind of hard to get exposed to that, what would you recommend for them?
I mean, one, come talk to me. Reach out and email me.
Any pharma investigations projects that maybe somebody could get hooked up in?
Yeah, actually, in developing the practice model here, we're going to have to develop projects, and I'm already brainstorming. I've drafted a medication severity score for CF, since a lot of different centers like this one have 200 to 300 patients at a center. It's hard for them to all see the pharmacist at every visit. And so how do we triage these patients to prioritize them? And so I developed a score that I'm going to try testing out here as part of quality improvement, just to see how it works in terms of workflow. But eventually I'd like to see that score maybe go into a multi-center study, because I know a lot of other pharmacists are looking for something like that.
Well, let's talk a little bit about your practice, because it's pretty unique, and you have a relationship with physicians, and maybe you're one of Michigan's too new. Maybe you want to talk about the Arizona one as a better example. That it incorporates you running a clinic, but it also incorporates research, for example.
Mm-hmm.
Can you kind of talk about how that all kind of works in this? Sounds like just a wonderful clinic experience.
Yeah, so from a clinical practice standpoint, I consider it my laboratory, right? Like, I don't have a traditional lab for my research, but I do a lot more research with regards to patient family education, adherence, and I've even helped out with, drug trials and things like that as well. And working with the physicians was really important in my career development. Honestly, a lot of my research growth and development is at the University of Arizona was attributed to my pediatric pulmonologist that I work with, because I was an N of 1 in peds at my College of Pharmacy at Arizona. And they really kind of pushed me out there, put me out there. Any opportunities for a PharmD to lead as PI, they put me out. They kind of voluntold me for things without telling me, and then telling me afterwards. Threw me in the fire, which was good, because then it exposed me to a lot of different research methodologies, and got my name out there from a CF Foundation standpoint, which is the main organization that funds a lot of research with regards to CF. And so having worked with physicians on various research projects, and then now leading my own adherence trial that's multi-center is a big deal for me, and hopefully a big deal for pharmacy, because it was the first one that was funded primarily for a PI that was a PharmD. So hopefully
it's
it does
pretty cool
well.
to be a PI as a PharmD. Not everybody realizes how difficult that was, particularly in the day. And your funding's from a different source. I mean, the Cystic Fibrosis Foundation. One of the things you just mentioned was that adherence is something that's very important to you. And now, as I think about it, when a medication can cost $300,000 a year every year for the rest of your life, and you have people living into their 70s, you can start doing the math, and even I can figure out that's really important.
Yes.
Talk me through how that works. If I'm a patient who's going to get a $300,000 med, like, I can't even think about what that's like.
Right. So this is a medication that's on top of everything else that patients are taking already. So persons with CF take various nebulized medications, they spend about 2 to 4 hours a day on their therapy clearance and inhaled medications. And so those modulators that are $300K a year are on top of those therapies. It's really hard when you have a really effective modulator therapy to convince your patients to take the other drugs that take 2 to 4 hours a day. And so I try to communicate the importance of it through discussing the outcomes that they want to see from their therapy, because they're looking for that lung function jump, feeling better. But a lot of patients and families may not realize that the research that's done to get that drug approved, all patients who were on that drug also stayed on all the chronic medications prescribed to them, including all those nebulized meds. And those were monitored. And so patients who did well also did well on their other adherence to other therapies. And so I try to reiterate that with the patients and families. Finance also scares them, unfortunately. And so I do bring up the fact that if patients are not adherent and filling their other medications and using their other medications, there is a risk that insurances may stop paying for Trikafta and other medications like it. Because insurances do have claims data access. And so they can see if they're filling their pulmozyme, they're filling their hypertonic saline, their inhaled antibiotic. And if they're not filling it, not using it, it might give the insurances a little bit of an okay to say, maybe we won't pay for the $300,000 drug.
You got the most expensive clinic. I don't know how many patients you were seeing, they probably don't all get that medication, but my goodness, your consumption rate, dollar consumption rate's got to be just incredible.
Yeah, and now with Trikafta, that covers about 80% of persons with CF. And so right now it's approved for 12 and up, but I'm anticipating they're going to drop the age to 6 in the next 6 months.
All right, I don't want to talk about CF all day, but I got a question that just came up, and it's an interesting one. I never thought about it before. CF is this genetic disease, and it's was always brought forth as the example. Sickle cell or cystic fibrosis were really always the two you would talk about when you talk about genetic diseases. And now I suppose there's bone marrow transplants for this, or thinking about, I don't know, is that such a thing even?
Lung transplant, yep.
Or lung transplant, okay.
Mm-hmm.
But are there also then like inter-individual, I suppose there must be inter-individual genetic differences, pharmacogenomic differences between people for the drugs that you get, and is that a whole nother layer of research?
Right. I still remember like being in my pharmacogenomics class and whatever, like even in fellowship, I took an extra course. I'm like, I'm not going to use this. This is not relevant to me. And lo and behold, I actually have to check genotypes on every patient every time I see them to make sure that they do or do not qualify for a CFTR modulator, which is the big expensive drug. So genomics is very relevant when it comes to CF. We need to know what CF genotype that they have. And so the CF Foundation actually pays for every patient to get tested once if their insurance will not pay for it, so that they know if they can qualify for the good drugs.
So the stuff we're teaching actually is important. So I guess that's good to know. So a lot of questions are coming up about adults and peds as a practice. So I'm going to ask you to stereotype here if you can. But have you noticed differences in ways that people approach problems or even patients if they're adult practitioners versus pediatric? Like, what do you think is different?
In terms, well, one, I think peds folks tend to be a little bit more think outside the box, but I could be wrong. My adult colleagues might argue otherwise. And it also depends who we're talking with and what area of practice we're in. I've noticed there's somewhat of a difference in terms of those who practice in ambulatory care in pediatrics versus those who practice, say, ICU in pediatrics. Those of us in the ambulatory care, we tend to be a little more chatty with our patients. That's why we're in ambulatory care, I guess.
And that's why I went to the ICU, so I don't have to talk to anybody.
Yeah, right? Although I enjoyed my time in the ICUs. But and then communication with patients and families is also somewhat of a difference. So like if you're educating an adult patient, you're telling them their risks, and it's an adult patient, hopefully they understand the risks and benefits of the therapy, and they may or may not choose to follow the advice. But it's harder for me sometimes when I am working with a patient and family where I know what I'm advising to the family is the right thing to do for the benefit of the child, but maybe the parent doesn't agree and then doesn't adhere to it or doesn't want to do it.
Sometimes they need a parentectomy. They need a new parent. And
that can be
or
hard. I've had cases where, it's like a 9-year-old child and the parents are basically handing responsibility of all medication administration to the child and expecting them to put on their own vest and do their own meds. And I'm like, they're 9. they can take some responsibility, but they're not an adult yet.
All right, so parents are a challenge. What would you say are the biggest challenges you experience as a pediatric practitioner?
Well, you do see some hard cases in pediatrics, including like non-accidental trauma, child abuse,
Non-accidental trauma.
neglect.
I didn't know
So
that.
those sorts of Debbie Downer sort of topics come up in peds sometimes. I will say that working in chronic disease management, I do occasionally lose a patient, and it's harder, I think, from a chronic disease standpoint, because I've known patients and families a very long time. At Arizona, whenever we lost a patient, our entire CF team actually attended funerals together as a team. But it does not happen as often. I will say that kids are very resilient, and we're much better at treating a lot of the diseases now, so we don't see it as often. But
that's CF. But I mean, peds onc, peds ICU can be tough. You can run its strings. I know. Is that the hardest part? That's got to be.
I think so. And when I was a residency program director, one of the things I would ask candidates coming in is, have you lost, you've had peds rotations, have you lost a patient yet, and how did you cope?
Okay, so I'm going to ask you your own interview question, because now everybody in the audience knows you're going to ask that question. So let's get what's the answer to that?
Each person has their own way to cope and manage. They just have to, either rely on, seek out support, but definitely don't try to fight it on their own. And if they haven't experienced it yet, pediatrics isn't always rainbows and sunshine. So realizing that you're going into a profession, you're a healthcare profession, so you're going to see both the celebrations, the good moments, as well as the not so great moments.
Yeah, and students, you're gonna see it. It's part of what we do. It's just part of what we do, particularly where you decide to practice. It's just part of what we do. Yeah. I got a question. I got a CF question here. So everyone wants to hear about this. I guess we do have to have more of this in the curriculum. All right, you're busy inhaling tobramycin and amikacin. You're giving every beta-lactam. Resistance has got to be crazy. Pseudomonas is a bug we're really worried about. What is a strategy or two you do to try to reduce resistance? And we're not going to colistin or crazy drugs, are we? Or are we?
I have. I have used a colistin
when they're all R's,
to adolescents and adults, but not small children.
Okay.
We do rotate the inhaled antibiotics. We do the on and off cycling for the inhaled tobramycin or S-Trianam. There are some patients who are on what's called continuous inhaled antibiotic therapy, where they're on an inhaled antibiotic no matter what. There's no off cycle, but we rotate what they're on. So hopefully we offset resistance a little bit longer. I tended to also rotate the antibiotics I used for exacerbation treatment. So if they were on something and they were recently admitted in the last 30 days, I would try not to use the same thing they were on last time if I could. So a little bit of stewardship in there.
All right. So I want to fast forward a little bit. You did serve as president of the Pediatric Pharmacy Association. Yeah. You've accomplished so many things in your career, which is why we recruited you hard to get you here. So there's a reason we wanted another national leader on our faculty. But I know you a little bit. It's not like you're this big extrovert. You might come across it on this show, but that's not really you, is it?
No, it's not. If I had a choice, I would have turned my camera off.
Okay, so how does one network we've got people in the audience who are introverts.
Yeah.
And then they look at you and they haven't met you yet. They don't know you're an introvert. You don't come across as an introvert on
yeah, a lot of people are surprised when they hear that. I am a professional extrovert, if that makes any sense.
I am also one. I am also an introvert. I don't like talking to people. And so here I am hosting the show, which is getting me out of my comfort zone. Give us a tip or two that you use as an introvert to be a successful networker.
Sure. So for example, in the Pediatric Pharmacy Association and PPA, when I first started as a member, I was probably the most quiet and silent person. People probably didn't even know I was there, to be honest. And having the encouragement of mentors to kind of push me outside my boundary and my comfort zone kind of helps. I know that, a few of my mentors are like, just talk to 4 people at the conference. Just go to a committee meeting, talk to 4 people. That's all I want you to do. And so I would actually do it. If I do what I'm told and I just go, I'm like, hi, I'm Hannah. I'm at the University of Arizona where I'm at so-and-so. This is the research committee. Okay, great. And then part of it was, if I was interested in something enough, I put myself out there. So if you guys are interested in being more active on a national level and you're an introvert, you got to take that first step. And I promise you, it's probably not going to be the most pleasant, but it'll pay off over time. Like, just take little baby steps here and there, put yourself out there, volunteer for things. I would volunteer to help with judging posters, which kind of really pushes your envelope when you're an introvert, because you have to actually go around and talk to people. And then, helping with white papers and publications or other things related to the committee. And then people start to get to know who you are, engage you in conversation even outside of stuff related to committees, and you kind of just flow into it. It's not easy when you first start, but if it's something that you're interested in doing and it's part of your career plan and passion and want and your goal, then baby steps. Nothing happens overnight.
Well, we do Strengths Finder for all our students early on to find out what are their 5 best strengths. And, use your strength to get through it, whatever that is. And maybe you're an empath. Maybe empathy was your thing. So just ask questions of other people. What's the one thing everybody likes to talk about? Themselves. Ask some questions. And sometimes if you're the introvert, you can just be quiet and listen, but you are networking and you're learning things. And it's a trick that I don't think we do nearly often enough. So if you have any more questions, again, put them forth. This has been great. There's been a lot of questions coming forth, which is wonderful. One of the questions that came out with, which I think is a neat one, is, so how did, in 2000, so we won't say the year, you graduated from here, you're a student. Now you're a faculty member.
Yeah.
Talk to me about that, and you've done a lot of mentoring in your career. Talk to me about this transition from being mentee to becoming mentor, from being the student to being a colleague. How's that work?
Well, I'm still a mentee. I think a lot of us are still mentees throughout our careers, but and I'm still a student of knowledge in general. Learn something new every day. I think initially, first going out and even teaching students in a classroom, I still get nervous to this day when I go lecture. I don't eat before I lecture or give a national talk, and really? I don't drink coffee because then I don't want to sound like a chipmunk. So I try not.
Okay. Good tricks. Write these down, everybody.
Right. I think part of it is like starting small and, teaching maybe experiential education with precepting, teaching one-on-one, and eventually growing out to doing like lecturing for students. For me, I just had to kind of be pushed into the pool, so to speak, during fellowship. Dr. Nahana was basically like, you're coordinating this course and you're giving the first lecture, and that's happening in about a month.
He was one of my mentors too. He's a great guy.
And he taught me tricks of the trade in terms of like trying to, breathe calmly and, things such as, for example, if you are a person who tends to push your glasses up when you talk a lot, if you wear glasses, if you have contacts, you might want to wear them the day you speak and go out and teach. If you're an introvert, if you play with your hair a lot, which I do, you'll notice if I give any talks anywhere, my hair is up for a reason. So
I play with the keys in my pocket. I always put my keys in my suit coat pocket or my back pocket so I don't play with my keys. We all have this dumb thing, and we just need someone to tell us what it is that we do, which is why we videotape our students giving their P4 seminar, just so they can see what it is that they do. It's painful to watch, but it's
I'm not going to lie. Like, it was a little bit nerve-wracking for me thinking about coming back as a faculty since I was a student. But I think for me, one, it's been 12, 14 years since I've at least been in Ann Arbor. So there's been enough time of a gap. But even seeing folks after fellowship and starting my new faculty job at Arizona and seeing you guys at like reunions or alumni stuff, I would still get super nervous. Like, Dr. Mueller, hi, how are you?
And now you know that I'm nice in real life. Well, more questions are coming in, and I think we're touching on something here about,
Great.
It seems like society doesn't value the introvert. It values the extrovert. And is there a stigma associated with being an introvert? Or how do you portray yourself?
I think there is somewhat of a stigma of introverts as either just not being interested or being loners, or I hate to say snobby. But, I think introverts, in a way, we all kind of just take in the world. And then when it's a right time, then we kind of make ourselves known and like make a statement. I think it's important to recognize that each of us probably are a little bit introvert and a little bit extrovert. We're just more one than the other, and even at certain different times. But as far as like kind of coming out of your shell, I think practice and time are probably the key things for that.
All right, so let's talk about that in the say, networking environment or the interview environment. If you're a person who's kind of naturally shy, introverted, you know, you got to come out with some energy. What,
Yeah.
any words of wisdom for the crew here? We got a bunch of P4s online.
Yeah. Well, definitely, you know, if you're interviewing for a particular place and that place is on your wish list, um, one, be yourself. You've got to be yourself to some degree, but at the same time, show your enthusiasm for that particular institution. I think they appreciate when you've done your homework and learned about the institution, are familiar with it, and have a connection to it in some way that really resonates with you as a candidate. Um, so just don't be a fake self. Like, we don't want to see night and day if you're interviewing, but at the same time, bring your game when you're
Energy
coming to
is
interview.
good. Do your research. Be ready to talk about something. I
Yeah.
agree with that. All right. So as we close this down here, there's a lot of folks interested, maybe considering a pediatric career, or maybe research in cystic fibrosis or pediatrics in general. Your practice is where?
At Mott Children's Hospital over at the ambulatory care clinics on the 6th
Okay.
floor.
Okay. And email, best way to get you
Yep.
to maybe talk about some of these things,
Yep.
because it's
I've
kind of
already
hard to.
actually had a few students reach out to me after the Instagram faculty takeover.
Yeah,
So
how was that?
it was interesting. Again, as an introvert, I was like, really? Can I just put a picture of myself like up and then just speak?
Holding a camera in front of you as a photographer.
I like to be
Well,
behind the lens, not in front of it. So
this was great, Hannah. Thanks for coming on board.
thank
Those of you in
you.
the audience who'd like to learn more, contact Hanna Phan at her email address, which is hfan@med.umich.edu. Hannah, great job today. So thank you so much.
Thank you. It's
And
an honor.
we're gonna do this again next week with Dr. Anna Schwendeman to talk about her research, which is really cool. Also using really expensive drugs, and it'll be fun to see what the farm side perspective is on these really expensive drugs, and actually putting together and making products in ways that they can be inhaled or whatever it is they're going to do, and however the nanotechnology drives them. So it'll be really cool to talk to her about her research. So I'll see you all next Thursday at 5:30 again. Thank you again, Dr. Phan, and
Thank
thanks
you.
everybody for coming.
Thanks, everyone.
Great job.
Thanks.